Imagine this. One moment, you're fine, totally healthy, just living your life, and then boom, this sudden kind of sneaky pain starts up in your abdomen, and it's not just, a regular stomach ache. It feels different, urgent, it gets worse, demands your attention. It's this medical emergency that feels surprisingly common, right? So many people know someone who's had it, but few really grasp the full picture, and it can just flip your world upside down, like really fast. Welcome to the Deep Dive. Today, we're cutting through all that noise to really unpack appendicitis. Our mission here is simple: to arm you with clear, essential insights. What it is, why it happens often for a surprisingly simple reason, how doctors figure it out when the signs aren't obvious, and what that road to recovery looks like. You're going to leave this feeling way more informed about something that is honestly a leading reason people end up needing emergency abdominal surgery. Okay, so we set the scene for this medical drama. Let's zoom in on the main character, the appendix itself. We all hear appendicitis, but what is it fundamentally? Is it just simple inflammation?
It is, at its core, pretty straightforward. Appendicitis means acute inflammation of the vermiform appendix. Simple definition. But while the definition is simple, its impact isn't small. We're talking about the most common reason for acute abdominal pain needing surgery right here in the U.S. Think about that. Over 5% of the population deals with this at some point. 5%.
Wow.
Yeah. And while it peaks, in teens and 20s, it really can happen at any age. Just important to remember, too, while inflammation is the big one, sometimes other things can affect the appendix. Certain tumors, even things like inflammatory bowel disease, can involve it sometimes. It's not always simple appendicitis.
5% is way more common than I think people realize. It just seems wild that this tiny little organ that most people don't even think about can cause such a huge, urgent problem. So what's the main idea behind why it suddenly gets inflamed like that? What kicks it off?
Well, the leading theory, and it's pretty well accepted, points to something quite mechanical. It's basically an obstruction, a blockage of the appendix's opening. That tiny little tube gets blocked.
Just blocked. By what?
It varies, but common culprits are things like enlarged lymph tissue, that's lymphoid hyperplasia, or sometimes a fecalith, which is basically a small, hard piece of stool. Less often, maybe a foreign object someone swallowed, or even a tumor, though that's rarer.
Okay, so something gets stuck, then what happens?
Right, once that blockage occurs, it triggers this dangerous sequence of events. The appendix starts to swell, it distends, because mucus and fluid can't get out. This swelling allows bacteria that are normally in your gut to overgrow inside the appendix. That leads to ischemia, basically. The blood supply gets cut off to the appendix wall, and then you get the intense inflammation. And if it's not treated, it progresses. The tissue starts to die. That's necrosis. It can become gangrenous. And the worst-case scenario, the one we really want to avoid, is perforation, rupture.
Right.
Sometimes if the body kind of walls it off with other tissues, a perforation might lead to an abscess, like a contained pocket of pus. But yeah, rupture is the big danger.
So it's really this chain reaction, all starting from a simple blockage. Swelling, infection, lack of blood flow, leading potentially to rupture. Sounds like you're racing against the clock. Okay, let's shift to what it actually feels like for the person going through it. What are those classic signs, the symptoms someone should be aware of? Because I gather it's not always just bang, sharp pain in the side.
Exactly. The classic story, the textbook progression, usually starts with this kind of vague pain. Often it's felt more centrally, like around the upper abdomen or near the belly button. Epigastric or periumbilical pain, we call it. And that initial discomfort, it's often followed pretty quickly by maybe some nausea, maybe vomiting, and usually a significant loss of appetite, anorexia.
Yeah.
People just don't feel like eating.
Okay, vague pain, nausea, not hungry.
But then comes the critical part, the hallmark shift.
Yeah.
After a few hours, maybe 4 to 6 hours, that pain typically migrates. It moves.
Moves where?
Down to the lower right side of the abdomen, the right lower quadrant. And this pain, once it settles there, usually gets sharper and worse with any kind of movement. Even just coughing or hitting a bump of the road can make it flare up. That migration is really characteristic.
And when someone gets checked out, there are specific things a doctor is looking for during the physical exam too, right? Things they feel for.
Absolutely. The physical exam is crucial. We're feeling for tenderness, specifically in that right lower quadrant, both when we press down directly and also sometimes what's called rebound tenderness pain that gets worse when pressure is quickly released. And we often pinpoint this tenderness at a specific spot called the McBurney point. It's a classic landmark for appendicitis.
McBurney point.
Yeah. And there are other signs too, specific maneuvers we might do, like the Ravsing sign, pressing on the left lower abdomen causes pain on the right. It is, right. Then there's the psoas sign pain, when we move the patient's right hip in a certain way, and the obturator sign, pain with a specific rotation of the hip. These suggest the inflammation is irritating nearby muscles. Oh, and a low-grade fever is pretty common, too. Usually not super high, maybe 100 to 101 Fahrenheit.
But here's the tricky part, isn't it? You said classic progression, but the body doesn't always follow the textbook. It's not always that clear cut. Must be a real puzzle sometimes.
You absolutely nailed it. That's the challenge. More than half, actually over 50% of patients present with atypical symptoms.
50%, that's a lot.
It really is. The pain might not move neatly to that lower right spot. Especially in babies and young kids, the location can be very different. Sometimes the tenderness is all over the abdomen, or rarely, maybe almost no tenderness at all. And bowel habits can be confusing too. Usually constipation is more common. But sometimes, if the appendix is in an odd spot irritating the bowel, you might actually see diarrhea.
Wow.
And it gets particularly tough with older adults and pregnant women. Their pain is often described as less severe, and that localized tenderness we look for might be much less obvious. So yeah, it makes the diagnosis much more challenging in those groups.
Which leads to the big question. If it is so variable, how do doctors actually confirm it's appendicitis, especially when those classic signs just aren't there? You don't want to wait too long, right?
Exactly. Time is critical. So here's the approach. When the classic symptoms and those physical signs we just talked about are clearly present, the diagnosis is mainly clinical.
Meaning based on the doctor's judgment?
Yes, based on the history, the symptoms, the physical exam findings. In those clear-cut cases, delaying surgery to get, say, a CT scan actually increases the risk of the appendix rupturing and causing bigger problems. So if it looks like classic appendicitis, the push is toward surgery promptly.
Okay, so clinical judgment is key in classic cases. Trust the experienced eye, basically. But what about all those atypical cases you mentioned, the 50% where it's fuzzy? That's where imaging comes in, I assume.
Precisely. For patients where the findings are atypical or maybe just unclear, equivocal imaging studies become really, really important. And they should be done quickly without unnecessary delay. We generally have two main tools. One is a contrast-enhanced CT scan. CT is very accurate for spotting appendicitis, and a huge plus is that it can often show other things that might be causing the abdominal pain if it turns out not to be the appendix.
Like what?
Oh, things like diverticulitis, kidney stones, ovarian cysts. Lots of possibilities. So CT gives a broader view.
Makes sense. And the other option?
The other main one is ultrasound, specifically graded compression ultrasound. Its advantages are that it's fast, readily available, and crucially, uses no radiation. That makes it a particularly good choice for children and pregnant women.
But downsides?
Yeah, it can be limited. Sometimes bowel gas gets in the way and makes it hard to see the appendix clearly. And it's generally not as good as CT for finding those other non-appendiceal causes of pain. And one more thing worth mentioning is laparoscopy. That's keyhole surgery. It can actually be used both to diagnose and treat appendicitis, especially useful sometimes in women with lower abdominal pain where the cause isn't certain. You can look around, and if it's the appendix, take it out right then.
Okay, so imaging is key for the unclear cases. What about blood tests? Do they give a definitive yes or no? Like, can a blood test rule it out?
That's a common question. Blood tests, specifically looking at the white blood cell count, often show an increased leukocytosis, we call it, usually in the range of 12,000 to 15,000.
So high white count means appendicitis.
Well, it's often seen, and this is really important, it's highly variable. Lots of things can raise your white count. And crucially, having a normal white blood cell count absolutely does not rule out appendicitis. You can definitely have appendicitis with a perfectly normal white count.
Ah, okay. So it's a piece of information, but not the deciding factor on its own.
Exactly. It's part of the puzzle, but you can't hang your hat on it, especially not to rule the diagnosis out.
Got it. So let's say the diagnosis is made, whether clinically or with imaging. What's the next step? What's the treatment plan? Is it always surgery?
Yes, the primary, standard, and recommended treatment for acute appendicitis is surgery to remove the appendix. That's the appendectomy. It can be done the traditional way, open surgery with a larger incision, or much more commonly these days, laparoscopically using small incisions and a camera.
And is it urgent? Like, how quickly does it need to happen?
Very urgent. Delaying treatment significantly increases the risks we talked about: rupture, abscess, widespread infection, which increases mortality. To give you an idea of the urgency, surgeons generally accept what's called a negative appendectomy rate of around 15%. That means they're okay with operating on 100 suspected cases and finding that 15 of them didn't actually have appendicitis.
Really? They'd rather take out a healthy appendix sometimes.
Yes. because the risk of missing appendicitis and letting it rupture is considered far greater than the risk of removing a normal appendix in a suspected case. It underscores how serious delaying treatment can be.
That really drives home the point about urgency. Now, antibiotics. You mentioned infection. Where do they fit in? Are they just supportive, or can they sometimes treat it on their own?
That's a really interesting area. Antibiotics are definitely a standard part of the treatment. 4V antibiotics, usually something like a third-generation cephalosporin, are given before the surgery starts to target the bacteria. And if the appendix has ruptured or perforated, then those antibiotics are continued after surgery, usually for maybe 4 days or so, to treat the infection that might have spread into the abdomen.
Okay, so standard before and continued after if it's ruptured. But what about using only antibiotics, skipping the surgery?
Right, there have been studies looking at this, and some show that antibiotics alone can resolve the appendicitis initially in a fairly high percentage of cases.
Oh, interesting. So why surgery then?
Well, the catch is the recurrence rate. A significant chunk of those patients who get better with just antibiotics end up having another bout of appendicitis within about a year, and then they need surgery anyway.
Ah, okay. So it might just delay the inevitable for many.
Pretty much. That's why surgery is still considered the definitive treatment, especially if the CT scan shows a clear blockage like a stone and atypical. That makes recurrence more likely. Now, if surgery is absolutely impossible for some reason, maybe the patient's too unstable or in a very remote location, then antibiotics are crucial and can definitely improve survival. But they aren't seen as the cure in the same way surgery is for preventing it from happening again.
That makes sense. Treat the infection, but remove the source of the problem. So pulling this all together, what's the outlook for someone who gets appendicitis? What's the typical prognosis?
It really depends heavily on timing and treatment. Without any treatment, either surgery or antibiotics, the mortality rate historically was quite high. It was a very dangerous condition. But with early diagnosis and prompt surgery, the picture is dramatically different today, especially in places with good medical resources. The mortality rate is very low, less than 1%, and recovery is usually quick and complete. Most people bounce back pretty fast.
That's great news.
It is. However, the prognosis does get worse if complications develop. If the appendix ruptures, if an abscess forms, or if peritonitis, that widespread abdominal infection sets in, the risks go up, recovery is longer, and mortality increases. And as I mentioned earlier, advanced age can also be a factor associated with a slightly poorer prognosis, just because recovery from major inflammation and surgery can be tougher.
Okay, that gives a clear picture.
Yeah.
So as we wrap up this deep dive on appendicitis, let's crystallize the absolute key takeaways for everyone listening. What are the most crucial points to remember?
All right, let's boil it down. First, if the signs and symptoms scream classic appendicitis, the priority is getting to surgery quickly. Don't delay for imaging in those clear cases. Second, if the picture is murky, atypical, or unclear, then imaging CT or ultrasound, particularly ultrasound for kids, is vital for making the right call. Third, antibiotics before surgery are standard, and if there was a rupture, they need to be continued afterward. And finally, fourth, while antibiotics are important for fighting infection, surgery remains the gold standard, the recommended definitive treatment, mainly to stop it from coming back.
Excellent summary. It's really quite something, isn't it? This condition that was once incredibly feared, often fatal, is now so manageable for most people thanks to these medical advances in diagnosis and rapid treatment. It really makes you think.
It does. And maybe a final thought for you to consider is just think about that rapid progression. How appendicitis can go from a seemingly minor blockage to a full-blown, life-threatening emergency in a matter of hours. It really highlights this incredibly delicate balance inside our own bodies, doesn't it? And at the same time, it showcases the amazing precision and speed that modern medicine often requires to intervene effectively. What does it maybe tell us about our body's hidden weak spots, perhaps? And also, its incredible ability to both deteriorate quickly and recover remarkably well when we get the right help at the right time. Something to mull over.